Okay, let's try and unpack this.
Mm.
Imagine you're expecting a baby, just filled with joy and anticipation, right? And then suddenly you get news that just profoundly changes that dream. News about significant health challenges.
Yes.
Suddenly you're kind of thrown into this world of complex medical terms, really difficult decisions, and just immense grief. How do families even begin to navigate that?
It's incredibly tough.
And what kind of support is actually available, not just for the baby, but for, the whole family?
Well, that's exactly what we're diving into today. This incredibly tender, but often really misunderstood field of perinatal and neonatal palliative care, or PPC.
PPC, right?
Our sources today, they really shine a light on how healthcare professionals become these guides almost, walking alongside families through just the most challenging moments of life and loss.
So our mission today is to filter through this comprehensive guide for healthcare pros, Handbook of Perinatal and Neonatal Palliative Care. We want to bring you the essential insights. Because we're talking about a field that really challenges how we usually think about things, it moves way beyond just giving up.
Absolutely. It's not about giving up at all.
It's focused on maximizing quality of life, comfort, and connection. Even when, tragically, an infant's life might be very brief.
Exactly. Connection is key.
So hopefully you'll get a much richer understanding of what it truly means to support these families. Okay, so when we first hear palliative care, especially with babies, I think a lot of people jump to end-of-life care. Is that accurate? Or maybe too narrow?
That's a really common starting point, but yeah, it is too narrow. I mean, think of it like this. All hospice care is palliative care.
Okay.
But not all palliative care is hospice care. See the difference?
Right. Got it.
Historically, the field grew out of these big landmark reports, in the U.S. They kept emphasizing this crucial point. Dignity, respect, comfort, these are universal human needs. They don't depend on age.
Right.
And what's really revolutionary here, I think, is that PPC isn't about choosing either curative treatment or palliative care. That's the old way of thinking.
Okay, so it's not an either.
No, not anymore. Current best practice, the gold standard, is actually concurrent care, doing both. Curative treatments and palliative care side by side.
Both at the same time. Wow.
Yeah, it means palliative care, with its focus on managing symptoms, can actually be brought in really early for fragile infants maybe facing long recoveries or potential developmental challenges, long before death is even, part of the immediate picture.
So it's not just for the very end.
Not at all. It's a real shift in thinking towards patient-centered care.
Okay, this sounds like a field where, gosh, every single word must carry so much weight. I imagine getting the language right isn't just helpful, it's like absolutely essential.
Well, absolutely. Conceptual clarity is paramount. Like, take advanced care planning. That's not just having a quick chat. It's really about informed and shared decision-making. About the care parents want for the birth for their infant, making sure these wishes are documented, but also, flexible.
Right, shared. That feels important, giving the family some agency.
Exactly. It gives them a sense of control. And then there's this difference between an interdisciplinary team and a multidisciplinary team.
Okay, I've heard those terms. What's the key difference here?
So an interdisciplinary team works interdependently. They work together towards a shared patient-centered goal. Everyone respects each other's roles. Communication is seamless.
Like a truly integrated unit.
Precisely. Whereas a multidisciplinary team, well, they tend to work more independently, side by side maybe, but not as integrated.
Ah, okay.
And that difference, it's not just academic. It really impacts how cohesive and supportive the family's care experience actually feels.
That makes total sense. Okay, now that we've got that foundational understanding, how does this specialized care actually get delivered? On the ground, it sounds like it can't possibly be a one-size-fits-all deal.
No, definitely not. PPC isn't just one single program. It's more like a spectrum of support.
A spectrum, okay.
Yeah, programs are usually categorized into primary, secondary, or tertiary levels.
Right.
It depends on the complexity of the situation, the provider's mission, their skills, and what specialized consultation is available.
So what does primary look like?
Primary PPC is sort of the foundational support. It should be available in most labor and delivery units. Think of families with a clear, life-limiting fetal diagnosis, like anencephaly, where the goal is a natural death. Core services should be there for them.
Okay. Basic, essential support everywhere, then secondary.
Secondary PPC is for more complicated cases, ones that need delivery and initial care in a more specialized fetal or neonatal center. Maybe a fetus with something like trisomy 13 and complex heart disease that can't be operated on. These families might desire evaluation or even attempts at curative treatments.
Right, more complex, needing specialized centers. And tertiary.
Tertiary PPC is for cases where there's short-term prognostic ambiguity, like really extreme prematurity or maybe a congenital diaphragmatic hernia with really poor lung estimates.
Where the outcome is very uncertain initially.
Exactly. These situations need a lot of neonatal and subspecialty input to make informed decisions. Often it means referral to larger pediatric or fetal centers quite early in the pregnancy. The key is these levels are designed to meet families wherever they are on their specific path.
Okay, that tiered approach makes sense. Now, something that really stood out to me from the source, this idea of a coordinator of care being like a mountain guide, that's such a powerful image. What exactly does that role involve?
Isn't it? It really captures it. The coordinator of care, often it's a nurse, maybe a genetic counselor, it's a social worker. They really do act like a
A
Sherpa,
Sherpa, yeah.
providing that consistent guidance for the family as they navigate this just daunting, unknown terrain. They're the main point of contact. They offer non-judgmental counseling about options, build rapport, address those initial worries.
So a single trusted person to turn to.
Exactly. They provide basic education about the fetal condition, guidance on what to expect next. They arrange appointments with specialists, connect families with all those vital resources, child life specialists, social workers, spiritual leaders, psychologists.
Wow, it's a huge coordinating role.
It is. And crucially, they guide the development of that comprehensive care plan, one that balances the obstetric goals and the neonatal goals, but always reflecting the parents' values and intentions.
So it covers everything.
Pretty much. Medical stuff, spiritual support, any desired rituals, ways to create legacies or memories, and even dispositional goals like autopsy or funeral arrangements. And it ensures everyone on the staff is on the same page.
That role sounds absolutely critical, just indispensable. But what are some of the bigger, maybe systemic challenges in making this kind of care actually available everywhere for all families?
Yeah, that's a major issue. Unfortunately, community-based neonatal and pediatric palliative care.
Well, it's just not uniformly available, especially in rural areas.
I can imagine.
There are significant barriers, things like provider bias, maybe a lack of experience with these kinds of non-traditional cases, and that persistent mistaken perception that PPC just means giving up.
Right, that misconception again.
Exactly. It's so critical that we actively challenge that perception. We need to integrate PPC as a fundamental philosophy of care, something woven into the fabric of the healthcare system, not just seen as some separate optional program. A philosophy, not just a service. That's a key distinction. Okay, let's shift focus now, right to the heart of it, the baby. When we talk about palliative care, comfort is obviously central. But for a newborn, what does that word really mean? It sounds like it's got to be more than just managing pain.
You're absolutely right. For newborn, comfort is.
Mm.
It's so much more than just not being in pain. It's a whole state, really, where their basic physiologic and psychosocial needs are being met.
Psychosocial too, okay.
Yeah. Studies looking at parents' perceptions, they show comfort means things like bonding, being held, not being cold or hungry or thirsty, and just feeling loved.
Feeling loved, wow.
So it boils down to a few core elements. The first, and maybe the most profound, is bonding.
Bonding.
It's not just nice to have. It's like the fundamental first need of a newborn, skin-to-skin care, just being held.
Mm.
It's actually crucial for neurological development.
Okay, so bonding first. What else?
Then, obviously, maintenance of body temperature. Simple things, right? Warmers, heat lamps, swaddling, skin-to-skin helps here too.
Keeping them warm makes sense.
And relief of hunger and thirst. This can be through normal breast or bottle feeds, maybe special nipples with support from a speech pathologist, or using feeding tubes like NG, OG, or G tubes.
Okay, what about for end-of-life care specifically?
Right, for end-of-life care, it might involve things like giving colostrum, the mother's first milk, rich in antibodies just for comfort, or using sucrose drops, other non-nutritive things just to soothe.
Comfort feeding, essentially.
Kind of, yeah. And then finally, what most people think of, alleviation of discomfort or pain. Assessing for signs like respiratory distress, air hunger, agitation, gasping. And using both non-pharmacological methods like gentle suctioning or changing position.
Things you can do without drugs.
Exactly. And then, when needed, pharmacological treatments like opioids or benzodiazepines.
It's incredible how many layers there are to just ensuring a baby's comfort. It makes me wonder, How do staff prepare for situations where there are physical anomalies? How do they help families see their baby as whole, as loved, despite those challenges?
That's a deeply sensitive area, and it requires really careful preparation and a lot of empathy from the staff.
Mhm.
Staff are trained for specific anomalies, like using special dressings for anencephaly, or maybe larger diapers for spinal issues. But crucially, the staff have to remain calm. Avoid any expressions of shock or disgust. That's vital.
The reaction sets the tone.
Absolutely.
Hmm.
And they need to actively point out the normal, the cute, the beautiful features of the baby. Always.
Focus on the baby, not just the condition.
Yes. And the physical anomalies.
Mm.
They should always be described to the family before they see the baby, or even before they see photographs.
Why before?
It gives parents a chance to process the reality first, to understand maybe what caused the death or the condition. It helps them integrate their baby's unique reality into their own understanding of wholeness and love. It prepares them.
That preparation sounds crucial. Okay, shifting gears slightly. These conversations sound like just the absolute most challenging that healthcare professionals could ever face.
They really are.
And the source mentioned that perinatal clinicians actually deliver devastating news more frequently than pediatric oncologists. That surprised me.
It's true. Infant mortality rates, sadly, remain significant. Congenital anomalies, prematurity, they're leading causes. So yeah, every perinatal clinician will face the need to deliver bad news.
So given that frequency, how can they be better equipped? Because the source also said many physicians report feeling uncomfortable, like they lack training.
Right, and that's a real gap. While a lot of the research and training models come from cancer care, there's a clear need for specific training here. The data does show that clinicians, especially physicians, sometimes dominate these conversations.
Talking more than listening.
Kinda, yeah. Spending less time really exploring the family's understanding, their questions, their values. But the good news is these communication skills can be taught.
Okay, so there are methods.
Definitely. There are training models like Ask, Tell, Ask. You assess their perception first, get the invitation to share information, then deliver the knowledge, address the emotion that comes up, and then strategize and summarize together.
Ask, tell, ask.
Or another one is NURSE, which stands for Name the Emotion, Understand it, Respect the Patient, Support them, and Explore the emotion further.
NRSE. Name, understand, respect, support, explore.
Exactly. These models, often taught using high-fidelity simulation, like with actors, have proven really effective.
That's good to hear that there are practical tools. Now, the source also mentioned this idea of the iceberg of conflict, that what's said is just the tip, right? What's underneath is the real issue. How does that apply in these ethical conflicts in PPC?
That's a perfect analogy for it.
Hmm.
In ethical conflicts, if you only focus on the positions, the surface level stuff, what people explicitly say they want, like we want this specific surgery.
Right, the demand.
Yeah. Focusing only on that often just escalates the conflict. Real transformation, real resolution requires digging deeper, investigating the interests beneath the surface.
The interests. Like what?
The underlying needs, the values, the motivations, even identity concerns for everyone involved, including the clinicians, by the way. We all carry conscious and unconscious biases, often learned culturally.
Biases in the clinicians, too.
Absolutely. So it's vital to incorporate multiple perspectives and always remember that families have their own moral reasons for their choices. Even if those choices seem, at first glance, to go against medical advice, there's usually a deeper why there.
That reframes conflict resolution entirely. Okay, so within this really delicate balance, how do you manage hope? How do clinicians give realistic information without just crushing a family's hope entirely?
This is what the source calls the titration of tenderness. It's a careful balancing act.
Titration of tenderness. I like that.
Yeah. Some clinicians might hold back on details because they're afraid of extinguishing hope. But actually, sometimes that can paradoxically hinder the grief process by creating false hope.
Ah, okay, so being too vague isn't always kind.
Exactly. Families generally need realistic expectations for their baby's time, however brief that might be. That allows them to shift their focus to making that time truly meaningful. And hope itself, it's dynamic. It changes.
It's not static.
Not at all. Parents might move from hoping for a cure to maybe hoping for comfort, or just hoping for time to bond, time to hold their baby. So it's vital for clinicians to gently ask, to ascertain, what are parents truly hoping for right now? Even if that miracle they first prayed for doesn't happen in the way they imagined.
Finding out what hope means to them at that moment.
Precisely. And if we link this to the bigger ethical picture, The standards for neonatal palliative care always prioritize the newborn's best interests.
Right, the best interests standard.
But, and this is a really crucial point the source makes, suffering cannot be assessed objectively in nonverbal patients like newborns. Clinicians' own values can, and often do, influence how they assess suffering.
So best interests isn't purely objective.
It can't be, entirely. And furthermore, understanding what's ethically right or wrong. That requires looking at the cultural context. Different backgrounds shape how people view these incredibly complex issues.
Culture played a big role.
A huge role. And maybe one of the most provocative ideas in the source is this concept that newborns have voices.
Newborns have voices. How so?
It challenges us, right, to look beyond just verbal communication, to really listen to the subtle cues, the expressions, the needs of these tiny patients. It's about acknowledging their inherent agency, their dignity, right from day one.
So it's about deep observation, interpreting their nonverbal cues.
Exactly. Practically, it means clinicians should try to involve even very young children in discussions, adapting to their level of understanding and communication, promoting their moral agency, helping them express their experiences, even if it's not through words. It requires real attunement.
That's a truly profound way to think about it. It really challenges a lot of traditional medical thinking, doesn't it? But practically, for a clinician, how do you really hear that voice from a nonverbal newborn? Especially when suffering is subjective and values differ.
It takes practice and deep observation, like you said, attunement. It means noticing those subtle cues, maybe a change in breathing pattern, a slight movement, a shift in muscle tone, and seeing that as communication.
Reading the signs.
Yes. And it also means trusting the parent's instincts. They're often the most attuned people in the room to their baby's unique ways of expressing comfort or distress. And just being open to different interpretations, always trying to prioritize what seems to bring comfort and peace to that specific baby.
Right, involving the parents as interpreters too. Okay, so this work clearly impacts everyone, the immediate family, extended family, friends, but also, crucially, the healthcare providers themselves. How does PPC support this whole broader ecosystem?
You're right, it's an entire ecosystem of care. Let's start with siblings. They are incredibly sensitive to the emotional climate, in the home, in the hospital.
They pick up on everything.
They really do. And they often desire and really benefit from chances to see their sibling, to say goodbye if needed. It's so important to use honest, concrete language about death with them. Avoid euphemisms like passed away or gone to sleep.
Be direct, but age appropriate.
Exactly. Younger kids might need the same explanation repeated several times, very simply. And clinicians have practical ways to help. They can prepare the hospital room, maybe look at it from a child's height, remove scary-looking equipment, create privacy.
Make the environment less intimidating.
Yes. And prepare the siblings beforehand. Show them pictures of the baby. Explain medical equipment in child-friendly terms like, a CPAP machine is a mask that helps air get into the body to help the baby breathe better. Maybe even let them touch or play with sample equipment on a doll.
Demystify it a bit.
Right. And memory making is huge for siblings too, involving them in creating keepsakes, handprints, footprints, maybe your recording of the baby's heartbeat on a phone, drawing pictures. These things make the baby feel more real, more tangible, and help create positive associations later on.
Giving them something concrete to hold on to.
Exactly. And finally, never underestimate the power of play. Play is how kids process things. It's how they work through grief, express emotions, and maybe regain some sense of control when everything feels chaotic.
Play is therapy. Got it. What about the parents themselves? The source mentioned re-goaling. What's that about?
Yeah, re-goaling. It's this profound emotional and cognitive shift that parents often go through. They start with hopes for a healthy baby, right? And then they have to adjust, shifting to new goals that align with their baby's actual condition and prognosis.
That sounds incredibly difficult.
It is. And something called good parent beliefs plays a big role here. For example, a parent whose core belief about being a good parent involves fiercely advocating, fighting for every possible treatment, they might initially resist shifting towards comfort care.
Because it feels like giving up the fight.
Right. Whereas another parent whose core belief is about ensuring their child feels loved and safe, they might be more receptive to comfort-focused care earlier on. It's about understanding those underlying beliefs.
So clinicians need to be aware of that.
Absolutely. Aware of the parent's beliefs and also aware of their own biases. Clinicians need to challenge their own assumptions to really support parents through that re-goaling process effectively.
And in that journey, I imagine genetic counselors play a pretty unique and important role.
Oh, absolutely crucial. Genetic counselors are expert navigators in this space. They address both the medical and the psychosocial issues. They provide unbiased info on genetic testing options, like what's the difference between diagnostic and screening tests? What about whole exome sequencing? What are the limitations?
Helping make sense of complex science?
Yes, and helping families understand recurrence risks for future pregnancies, exploring reproductive options. Their whole role is centered on patient autonomy, really active listening, empathy, guiding families to make informed decisions, even when they're facing what the source calls toxic knowledge.
Toxic knowledge, meaning really distressing medical information.
Exactly, or just significant uncertainty about the prognosis. They help families navigate that incredibly difficult emotional and informational landscape.
It's clear this support is vital across the board, but how does PPC fit into really high-stakes medical situations, like complex surgeries or those incredibly premature births?
It's vital there too. Even in surgical settings, think about high-risk fetal surgery or major surgery right after birth. Parents face just agonizing choices.
Unimaginable decisions.
Right. PPC clinicians can compassionately help families understand the possible clinical paths, explore their hopes, their fears. And this is where that idea of parallel planning comes in again.
Parallel planning,
Yeah.
right? Hope for the best.
And we'll help with the rest. That's the idea. You prepare for success, you hope for the best outcome from the surgery, but you also prepare for potential complications or the possibility that things might not go as hoped. You make sure that alternative path, the comfort-focused path, is also discussed and planned for.
So families aren't caught completely unprepared if things take a difficult turn.
Precisely. And PPC is also essential in those unexpected, extremely premature deliveries, especially in the periviable period, that window around, say, 20 to 25 weeks, plus 6 days gestation.
Where survival is so uncertain.
Exactly. Infant death rates are very high. Long-term complications are common for survivors. PPC services, with their interdisciplinary team approach, are just invaluable in supporting parents through prenatal decision-making, setting goals of care, providing that crucial psychosocial support for these incredibly vulnerable families.
Okay. Now, the source mentioned that most deaths in the NICU actually happen after withdrawal of life-sustaining therapies, or WLST. That sounds like an incredibly difficult process for everyone.
It is profoundly difficult for families and clinicians alike. This is where those communication strategies we talked about, like spikes or remap, become absolutely essential frameworks for guiding these sensitive discussions.
Spikes and remap, right.
Planning for WLST involves several key things: anticipating how the dying process might unfold, managing symptoms effectively with comfort measures, both pharmacological, like medications, and non-pharmacological, like positioning or swaddling.
Managing symptoms is key.
Absolutely. Considering the location of care, should it be in the NICU? A private room? Can the family take the baby home with hospice support? And crucially, providing ample opportunities for memory making. Photos, spiritual rituals, keepsakes, those heartbeat recordings.
Creating lasting memories.
Yes, and one really important point is to prepare families for the possibility that the infant might actually survive longer than expected after therapies are withdrawn.
Longer. That sounds counterintuitive.
It can be, but it happens. And
Right.
if families aren't prepared for that possibility, it can be a significant source of additional distress. So managing expectations around the timeline is also part of that compassionate communication.
That's such an important nuance. Okay, we've explored the incredible depth of communication, compassion, the support for families, but it's undeniable that this work must take an immense emotional toll on the caregivers themselves.
Oh, absolutely, it does.
So how do we make sure they are supported? How do they find meaning and avoid burnout in such demanding roles?
That's a critical question. Care providers definitely experience significant spiritual and emotional effects from constantly witnessing pain and suffering. It can lead to something called moral distress.
Moral distress.
Yeah, it's that feeling when you know the right thing to do ethically, but you feel constrained from doing it. Like maybe feeling pressured to continue life support when you truly believe it's no longer in the child's best interest, causing suffering.
I can see how that would be incredibly difficult.
It is. So, fostering well-being and counteracting burnout requires intentional strategies. Reflective practice is one key approach.
Like journaling.
Exactly. Journaling, or even just using smartphone notes or saving images to capture experiences, feelings. The source gave an example of a nurse saving a photo of a beautiful sunset taken after a really stressful shift, just as a grounding reminder of beauty amidst the difficulty.
Little anchors. What else?
Reconnection to purpose. Taking time to reflect on why they entered the profession in the first place. What was their initial calling? finding ways to stay connected to that core motivation.
Remembering the why.
Yes. The power of music is mentioned too. Using music, shift mood, connect to memories, provide solace. It can be helpful for staff and even for the tiniest babies.
Music therapy for everyone.
In a way, yeah. And finally, ritual. Co-creating rituals within the team. Maybe a blessing of professionals' hands before a difficult situation. Staff memorial services to honor the babies they've cared for. Team debriefings after a loss. These things help honor the experiences, provide meaning, and build that sense of community and shared support.
Rituals to process and connect.
Exactly. And there are even tools like the Perinatal Grief Intensity Scale, or PGIS. It's a research-based questionnaire, validated from others, that helps identify parents who might be at higher risk for intense, complicated grief after a neonatal loss.
So you can target support.
Precisely. It allows for more targeted professional support. It really underscores that grieving parents and the caregivers supporting them need ongoing help long after the immediate crisis has passed.
What an incredibly powerful and really nuanced deep dive this has been. We've explored how perinatal and neonatal palliative care. It's really not about the absence of hope, is it?
Not at all.
It's more about refining hope, about supporting families and caregivers through just profound loss, focusing on dignity, comfort, and those absolute essential human needs for connection and love.
It truly shifts the whole perspective, I think. Away from just battling death towards embracing life, however brief that life might be, making every single moment meaningful.
Yeah.
It really highlights the immense privilege and the huge responsibility of walking alongside families in their most vulnerable moments,
Yeah.
doing it with a compassion, clear communication, and just a deep commitment to preserving the human spirit.
So listening to all this,
Yeah.
what does it mean for you? And maybe consider this. How do you or how do the people around you define a life worth living? Does duration matter most? Or quality? Connection? And how might embracing this idea of parallel planning, hoping for the best outcome while also preparing with tenderness for potential challenges, how might that reshape how you approach difficult conversations or just uncertainty in your own life?
That's a deep question.
It's just a profound reminder, I think, that even when facing the unthinkable, there is always, always room for profound love, for meaningful connection, and for dedicated, compassionate support.
Absolutely. And we really encourage you to continue your own deep dives. Keep exploring complex topics like this, always armed with curiosity and an open mind.
Until next time, keep exploring.